Continue with microcytic hypochromic anemias. So microcytic means already we discussed the tail conditions. So in that L is lead poisoning. So lead actually inhibits the chelatase and also LR dehydrase. So because of this enzymes inhibition of this, it will lead to decreased heme synthesis. So coming back to here, when there is decreased heme synthesis, you can understand the protoporphyrin free levels will increase, and also there is increased RBC protoporphyrin. Also inhibits rRNA degradation, that is RBCs retain aggregates of rRNA, that is basophilic stippling. So you can remember the symptoms of lead poisoning by LEAD only. L means lead lines on gingivae that are called Burton lines, and also you can see on metaphysis of long bones on X-ray. You can see here these lines are the lead lines. And next, encephalopathy and also erythrocyte basophilic stippling, abdominal colic and sideroblastic anemia, and also drops, that is breast and foot drop, and nephropathy, injury to proximal convoluted tubule, neuropathy, that is chop breast and foot drop breast and foot. So treatment is chelation with succimer and EDTA dimercaprone. Exposure risk increase especially in old houses which are with chipped paint, and children. In children you may see behavior and developmental delay. And it's coming to sideroblastic anemia. Here the problem is mainly it is failure of making protoporphyrin. So if protoporphyrin is not made, then the free iron will be increased, right? So iron can't bind hemoglobin, and hereditary X-linked condition, and erythrocyte protoporphyrin levels will increase because erythrocyte protoporphyrin levels will decrease, but iron levels may increase. So this is a genetic cause. You can see here iron level is increased ferritin, but the transferrin is decreased because already there is high ferritin, and the serum ferrum will also rise. The causes are genetic, like X-linked, as we discussed, like elasynthesin, acquired myelodysplastic syndrome, and also it can be reversible in the case of alcohol. If we stop drinking alcohol, then it may be reversible. It may also lead to lead poisoning. Vitamin B6 deficiency, copper deficiency, drugs like isoniazid, linezolid, all this can cause sideroblastic anemia. Lab findings, as I said, increase iron, decrease TIBC, increase ferritin, ring sideroblast with iron-laden Prussian bruise stained mitochondria seen in bone marrow. You can see here in the bone marrow, very important that this collection is seen, sideroblastic anemia is seen mainly in the mitochondria. In the peripheral blood smear show basophilic stippling, that is a dotted, that is a peripheral basophilic stippling of RBCs. Some acquired variants may be normocytic or macrocytic. So sideroblastic anemia also can be either normocytic or macrocytic sometimes. So treatment is pyridoxine, that is you should give vitamin B6 and also cofactor for elasynthesis. Why vitamin B6? Because you can see here the causes. Vitamin B6 deficiency may also cause sideroblastic anemia, so treatment is vitamin B6. Next, coming to interpretation of iron studies. So in iron deficiency anemia, you can clearly understand there is low iron, so low serum iron, and chronic disease also. First we'll see about iron deficiency. Low iron, transferrin will be increased because low serum ferritin, so transferrin will be increased. Ferritin will be decreased because already low iron. Percent saturation also will be decreased. Next, coming to chronic disease. In chronic disease, there is low iron. Actually here the cytokines are affecting because of inflammation, the ferro portion is blocked, right? So there is low iron and there is low transferrin, but very important, ferritin is increased. Why ferritin is increased? Because ferro portion is blocked. When ferro portion is blocked, iron stores are increased, so ferritin is increased. As ferritin is increased, transferrin is decreased, but serum iron is decreased. This is very important. In the serum, iron is decreased because ferro portion is blocked, and percent transferrin saturation is also decreased. Always remember this percent transferrin saturation is similar to serum iron. That is what I remember. Next, coming to hemochromatosis. You can clearly understand hemochromatosis means accumulation of iron. So serum iron will increase, whereas transferrin will decrease and ferritin will increase. Of course, as I said, serum iron is always related to the transferrin saturation, so that is also increasing. Pregnancy or OCP use. Here the serum iron will be normal, or you can say decreased. but the transferrin will be increased because in a pregnant female there is higher chances of using iron, so transferrin will increase. Ferritin may be also decreased or normal, whereas transferrin saturation will decrease. Okay, so next you can see transferrin transports iron in blood. TIBC is indirectly measuring the transferrin. Ferritin is a primary iron storage protein of body. The evolutionary reasoning, pathogens use circulating iron to thrive. So the body has adapted a system in which iron is stored within the cells of body and prevents pathogen from acquiring circulation iron. Okay, very clear. So microcytic anemia will conclude this. Decrease iron is seen in iron deficiency, anemia of chronic disease. Very important, remember chronic disease means here the cytokines are attacking ferroportion. Decreased globin is seen in thalassemia. If alpha globin is decreased, alpha thalassemia. If beta globin is decreased, beta thalassemia. In alpha thalassemia also, if you remember, there is HbH type and Hb baths. HbH types there is accumulation of beta globin, and Hb baths there is accumulation of gamma globin. That is important. Hb baths, gamma globin. Okay, and in beta thalassemia, very important one is beta thalassemia major, which is also called Cooley anemia, and in that you know that the beta globin is decreased, and if it is affected with parvovirus B19, it will lead to aplastic crisis. Why? Because parvovirus B19 already decreased the their precursors to decrease, so already they are affecting with the beta thalassemia. That patients will have low blood, RBC, all those things. So again, if parvovirus can act on it, then it will lead to aplastic conditions. Next, decrease heme. It is seen in lead poisoning and sideroblastic. In sideroblastic especially, there is decreased porphyrin. In lead poisoning, as it is acting on ferrochelatase and LR dehydrase, it will directly decrease the heme synthesis. Next, let us discuss macrocytic anemias. Here MCV will be greater than 100. Actually, here the problem is there is impaired DNA synthesis. So the maturation of nucleus of precursor cell, there will be more maturation of precursor cell, and that will lead to a maturation of cytoplasm. And the causes are especially vitamin B12 deficiency and folate deficiency, medications like hydroxyaphenita and methotrexate. In this condition, there is increased mean corpuscular volume, but there is decreased hematocrit or anemia. Hematocrit is decreased here because actually here the problem is there is impaired DNA synthesis. So because of that, the cell is becoming larger. So other causes like liver disease, alcohol, reticulocytosis. In reticulocytosis, you can see like more red blood cells are dividing. They are dividing more so that the size is high, but the hemoglobin is low. So findings are, you can see RBC macrocytosis, hypersegmented neutrophils. So you can see clearly this is a hypersegmented neutrophils. So remember megaloblastic anemia, you can see hypersegmented neutrophils. So these are the causes like folate deficiency, vitamin B12. Why they are causing macrocytic anemia? Let us see. Folate deficiency mainly due to malnutrition like chronic alcohol overuse. Because of chronic alcohol overuse, important enzymes are not getting absorbed from intestine. There's malabsorption, and there's drugs like methotrexate, trimethoprim, phenytoin, and increased requirement because of hemolytic anemia pregnancy. There there's higher use of folate, so that it is leading to folate deficiency. So in folate deficiency, findings are increased homocysteine but normal methylmalonic acid, but there are no neurological symptoms. But in vitamin B12 deficiency, you'll get neurological symptoms. It is causing pernicious anemia. Causes are pernicious anemia or malabsorption like Crohn's disease, pancreatic insufficiency, and also gastrectomy, insufficient take like vegan, and also Diphyllobotrium latem, fish tapeworm, can cause this deficiency. Here there is increased homocysteine, increased methylmalonic acid, and there is also neurological symptoms like reversible dementia, subacute combined degenerative degeneration, involvement of B12 in fatty acid pathways, myelin synthesis, cerebrovascular tract, lateral corticospinal tract, dorsal column dysfunction. Folate supplementation in vitamin B12 deficiency can correct anemia but worsen neurological symptoms. Very important. Folate supplementation in vitamin B12 deficiency can correct the anemia, but it will worsen the neurological symptoms. This is a very important point to remember. And histologically diagnosed with Schilling test. So it's a test that determines the cause is dietary insufficiency or malabsorption. If anemia is secondary to insufficient intake, then may take several years to develop. due to liver's ability to store B12. Actually, if someone is getting B12 deficiency, it is like going on from several years because already liver tries to produce B12. But folate deficiency takes weeks to months. Folate deficiency only takes weeks to months. Now coming to orotic aciduria. Actually, it is an inability to convert orotic acid to UMP. UMP means, so here there is a defect in UMP synthesis. So because of that, you can see here unable to convert orotic acid to UMP. So it is actually autosomal recessive. It is present in children as failure to thrive. There will be developmental delay and also megaloblastic anemia, which is refractory to folate and B12. There is but no hyperammonemia because you need to compare this with ornithine transcarbamylase deficiency, where there is increased orotic acid with hyperammonemia, but here in orotic aciduria, remember, there is no hyperammonemia. Okay, and orotic aciduria, in the name itself you can see that is the orotic acid is present in the urine. Okay, and the treatment is uridine monophosphatase or uridine triacetate to bypass mutated enzyme, because here the defect is UMP is not present, so for treatment we'll give UMP only. Now coming to non-megaloblastic anemia, here also there is macrocytic anemia, that is the MCV is greater than 100. In this the DNA synthesis is normal. If you remember, in megaloblastic anemia the DNA synthesis is abnormal, and here the causes are chronic alcohol overuse, liver disease, and there is RBC macrophytosis without any hypersegmented neutrophils. If you remember, in megaloblastic anemia there are hypersegmented neutrophils. Now coming to diamond black fan anemia. What is this diamond black fan? It is a congenital form of pure red cell aplasia. So I remember red cells as diamond. Okay, diamond black fan anemia means lack of red cells, only red cells, that is RBCs. Whereas if you compare it with Fanconi anemia, in Fanconi anemia it is pancytopenia, means all the cells are gone, like RBC, WBC, platelets, everything are gone in this. But here it is purely a red cell, only RBCs are gone here in diamond black fan anemia. It is a rapid onset anemia within first year of life due to intrinsic defect in erythroid progenitor cells. So actually here the problem is in the erythropoietin cells, so they are unable to produce RBC. Here so hemoglobin F will be high, that is, in hemoglobin F there is no beta chain, right, and there is short stature in these people because of lack of RBC, and there is craniofacial abnormalities and also upper extremity malformations like triphalangeal thumbs in up to 50% of cases. So now let us continue with normocytic normochromic anemia. Normocytic means here the MCV will be between 80 to 100, and actually it is divided into non-hemolytic and hemolytic. That is hemolytic means the blood cells will get breakdown. Non-hemolytic means they will not get breakdown. Okay, and hemolytic anemia are further divided into intrinsic and extrinsic. That is where they are getting breakdown. They are getting breakdown within the blood vessel, or extrinsic means they are getting breakdown in spleen or some liver, like that. So by the location of hemolysis, it is divided into intravascular and extravascular, and whenever there is hemolysis there will be higher amounts of LDH, reticulocytes, by reticulocyte, because already these blood cells are undergoing breakdown, so the precursors will increase, they'll try to raise them, and unconjugated bilirubin is because if the hemoglobin breakdown, that the unconjugated bilirubin will rise, and that will lead to pigmented gallstones that they'll accumulate in the gallbladder, and also you can see urinobilinogen in the urine. Now coming to intravascular hemolysis, actually here there is decreased haptoglobin. What is haptoglobin? It is an acute phase reactant which is mainly seen in inflammation. So here the cystocytes are increased on blood smear, that's why they are undergoing intravascular hemolysis, because that cystocytes are abnormal red blood cells. So because of their membrane defects, actually always remember intravascular hemolysis affects the problems where they're having some membrane problems, so that they are getting destroyed in the blood vessels. So characteristic hemoglobinuria, of course, because RBC is getting destroyed, there will be hemoglobin in urine, and also increased reticulocyte and hemosideruria, and also urinobilinogen in urine. There are like examples, you can see paroxysmal nocturnal hemoglobinuria. Here in the name itself you can see there is hemoglobinuria, then you can clearly find out it as intravascular hemolysis. And microangiopathic hemolytic anemia, here also the same thing. I'll discuss this in detail in next videos. Next, extravascular hemolysis is most common in liver and spleen. One more thing, in intravascular hemolysis you will see brown red color urine. Here extravascular, it is common in liver and spleen. Here actually the macrophages in the spleen try to clear the RBCs normally. So here you can see splenomegaly. Because of this spleen is trying to cut down many RBCs, so spleen will become enlarged with abdominal pain. And also you can see spirocytes and peripheral smear, most commonly due to hereditary spirocytosis and autoimmune hemolytic anemia. Okay, there are many spirocytes. These are also abnormal shape of the RBCs, so they are getting destroyed. It is mostly due to heredities, like from the birth they are like that, or some autoimmune hemolytic anemia. And there will be no hemoglobinuria or no hemosideриnuria, because it is nowhere related to the bloodstream. It is getting destroyed directly in the liver and the spleen. So it can present with urobilinogen in urine, but this is common, urobilinogen in urine. Okay, now coming to non-hemolytic normocytic. So we have discussed hemolysis as intravascular, extravascular. So there is also normocytic anemia there, where the MCV is between 18 to 100, but without any hemolysis. So they are like anemia of chronic disease. Already I discussed here, because of cytokines, inflammation, hepcidin will be increased. Hepcidin is actually released by liver, binds the ferro portion on interstitial mucosal cell and macrophages, so inhibiting the iron transport. Already discussed that ferro portion is present for transport of iron between the cells and the blood circulation. So if this is blocked, then what happens? Because of inflammation, this is blocked. So all the iron is inside the cell, and there is no iron in the serum, which is available for the production of RBC. Okay, so decreased release of iron from macrophage, decreased iron absorption from gut, associated with conditions like chronic infection, neoplastic disorder, chronic kidney disease, autoimmune disease like SLE, rheumatoid arthritis. So findings are very important here. Iron is decreased, but the transferrin is also decreased, because already there is lot of ferritin inside the storage of cells. So it is normocytic, but can become later microcytic. If you remember, we have discussed this anemia of chronic disease in normocytic and also microcytic anemia. Treatment is to address underlying cause of inflammation, judicious use of blood transfusion, consider erythropoiesis stimulating agents like EPO, example in chronic kidney disease. Chemical causes for this disease may be benzene, chloramphenicol, and also methimazole PTU. Actually, this methimazole PTU are used for thyroid diseases, right? Now coming to the aplastic anemia. Actually, aplastic anemia is pancytopenia, that is all type of cells are gone, like RBC, WBC, platelets, everything. It is most common idiopathic. It is T cell mediated destruction of stem cells. Treatment is anti-thymocyte, globulin, cyclosporin. So let us see what is going on here. Actually, it is failure of destruction of hematopoietic cells, reduce volume from inside. Especially in diaphysis, you know that most of the cells are forming. Also due to radiation, viral agents like parvo B19, acute viral hepatitis. Actually, parvo B19 will decrease erythropoiesis by decreasing the progenitor cells, especially if this parvo B19 already affects the hemolysis patient, then it will lead to severe destruction of RBC, because already they are lacking already they are having hemolysis, and again if this virus acts, that will lead to severe drop in RBC, and that will lead to pallor, weakness, and also aplastic crisis, that is decreased reticulocytes also. Fanconi anemia is actually autosomal recessive DNA repair defect, where there is bone marrow failure, and normocytosis or macrocytosis can be seen on CBC. And idiopathic, that is immune mediated primary stem cell defect, may follow acute hepatitis. All these are causes of this. D, drugs like benzene, chloramphenicol, alkylating agents, antimetabolites, all can lead to aplastic anemia. So here the lab values will be decreased reticulocyte count and increase erythropoietin. As already erythropoietin is high, reticulocyte count will be low. There's pancytopenia caused by, characterized by anemia, leukopenia, thrombocytopenia, and normal cell morphology, but hypocellular bone marrow with fat infiltration, that is important. You can see here, these are the fat cells. Fat cells are getting accumulated inside the bone instead of the stem cells, which should form all this blood cells. And the symptoms are fatigue, malaise, pallor, purpura, mucosal bleeding, petechia, infection. So always one key point is, whenever there is petechia, you can see there is a platelet defect. Okay, and whenever there is pallor, you can say anemia, that is RBCs are low. Whenever petechia, you can say platelets are low. Whenever there is infection, you can say WBCs are low. So treatment is withdrawal of offending. So offending agent or immunosuppressive regimens like anti-thymocyte, globulin, cyclosporin, bone marrow allograft, RBC platelet transfusion, bone marrow stimulation by GM-CSF, colony stimulating factor. Okay, and you can see here the Fanconi anemia. It is autosomal recessive or X-linked. It is seen in children less than 16 years. They are presenting a short stature, cafe-like spots, malformed. Uh, there can be malformed. What is this? Sorry, heart, eye. They may also present with heart, renal, and eye problems. This increased risk of malignancy and involve the DNA repair enzymes. It is pure red cell aplasia means there will be thymoma and decreased reticulocyte. If you remember, pure red cell aplasia is diamond black fan anemia, where that is associated with thymoma and there is decreased amount of reticulocytes. Now let us start with intrinsic hemolytic anemia. Intrinsic, actually, I said already here, the blood RBC will get distracted within the blood vessel. So intrinsic here, mainly the problem will be about the membrane. So whatever the disease you take here, the problem will be about membrane. So if you come to hereditary spherocytosis, so hereditarily there is a spherocytosis. The RBC should be always in biconcave shape, but here the shape is changed. So because of that, it will get destroyed in the intrinsic pathway. So, and one more thing, in post splenectomy you will see oval jolly bodies here. So you can see here primarily autosomal dominant, defect in proteins with RBC membrane skeleton, like especially ankyrin, band 3 protein, spectrin. So small RBC with no central pallor, decreased surface area, increased MCHC, premature removal by spleen. So as they are, like you can see, the shape is abnormal. They are prematurely removed by spleen. That is extravascular hemolysis. Splenomegaly will be there, pigmented gallstones, aplastic crisis if parvovirus B19 affects, because already I said if there's decrease, already there's hemolysis and again parvovirus B19 acts, it decreases all the precursors, so that will lead to aplastic crisis. And in labs you see decreased mean fluorescence of RBCs, EMA binding test, and increased fragility in osmotic fragility test. Increased fragility because this membrane will become very thin. This RBC membrane will become very thin because of spherocytosis, and when you do the fragility test, it will easily break down. So RBC hemolysis with exposure to hypotonic solution. Normal to decrease MCV with abundance of RBC. So actually here the mean corpuscular volume will decrease with abundance, but lot of RBC. Now coming to paroxysmal nocturnal hemoglobinuria, in the name itself we can say at the night there will be more hemoglobinuria, means more hemoglobin will be present in the urine. That is why here the membrane, some membrane problem, so the RBC is getting destroyed here. So loose iron in urine, abdominal pain, thrombosis. It is also related to acute myeloid leukemia. There will be increased smooth muscle tone. Okay, so loss of GPI, that is hematopoietic stem cell mutation, increased complement mediated intravascular hemolysis, especially at night, acquired PIGA mutation, impaired GPI synthesis for decay accelerating and membrane inhibitor, and which protect RBC from complement. So here there will be Coombe negative hemolytic anemia, mainly intravascular, and pancytopenia, venous thrombosis. Venous thrombosis in Budd-Chiari syndrome. Pink or red urine in the morning associated with aplastic anemia, acute leukemia. Lab CD55-59 negative RBC on flow cytometry. So here we do flow cytometry for paroxysmal this one, whereas in hereditary spherocytosis we do fragility test. Okay, and labs you can see, and the treatment is eculizumab, which targets terminal complement C5. You can see here, prevent the cleavage of complement. Actually here the complement is breaking, so that is the reason why this membrane is getting disturbed. Now coming to G6PD deficiency. It is a key enzyme for HMP shunt which produces NADPH. It is most common human enzyme disorder. Actually, it is X-linked recessive, most common in males. So G6PD defect decrease NADPH, so decrease glutathione. So increase RBC susceptible to oxidative stress. So here the more chance that the RBC get distracted, especially if you use sulfur drugs, anti-malarias, fava beans, all this will lead to hemolysis, even aspirin. So this causes extravascular, intravascular, both kinds you can see. Fail to fluorescence under UV light. Okay, and there is association with back pain, hemoglobinuria, few days after oxidant stress, decreased G6PD activity, may be falsely normal during acute hemolysis. Blood smear shows RBCs with Heinz bodies. This is important. Heinz bodies and bite cells. Bite cells are seen because the spleen is destroying this cells, so the spleen is eating up these cells, and that is leading to bite cells. And Heinz bodies are formed with stress. Makes me eat bites of fava beans with Heinz ketchup. So this is a mnemonic to remember. Is coming to pyruvate kinase deficiency. Here also again membrane failure. It is autosomal recessive defect, decreased ATP, rigid RBCs, extravascular hemolysis, increased levels of 2,3-BPG, decreased hemoglobin affinity for oxygen. So here also membrane problem, decrease ATP and RBCs will become rigid, so that they'll get destroyed in the blood vessel or outside. So it is also hemolytic anemia in newborn. Labs are blood smear show Burr cells. So Burr cells are present in pyruvate kinase deficiency. Here also there is splenomegaly. Now coming to sickle cell anemia. So you can see the sickling of cells. This is called sickle cell. It is point mutation in beta gene. That is single amino acid substitution. That is the glutamic acid is substituted to valine. So this mutant HBA is termed HBS. So now hemoglobin normally in adults is A, but because of the substitution of valine, it is converted into HBS. So this causes extravascular and intravascular hemolysis. So pathogenesis is low oxygen, high altitude or acidosis precipitates sickling. So actually what happens is whenever there is low oxygen, this blood cells will try to sickle. They form this sickle shape, and because of this deoxygenated HBS polymerizes, and that will lead to anemia. You can see these cells are easily struck inside the blood vessels and they get destroyed, and also they are stuck in the spleen, and spleen tries to destroy them. So in sickle cell anemia you can see both extravascular and also intravascular hemolysis. So this is a vaso-occlusive crisis, especially you can see this in newborns which are asymptomatic because of increased HbF. But in as I'm saying here, the mutation is in HbA, but you know that infants have HbF, so initially there will be no problem for them, but later they will see the problem because of HbS, which is formed due to glutamic to valine substitution. But the ESR is decreased. Heterozygous sickle cell trait have resistance to malaria. That is important. And sickle cells are crescent shaped RBCs, screw cut on skull X-ray due to marrow expansion from increased erythropoiesis. Actually, because of the sickle cell, more blood cells are undergoing hemolysis, so our bone marrow tries to compensate it with increasing erythropoiesis. And this is also seen in thalassemia, the same thing. Okay, here you can see osteoporosis because the bone is getting destroyed more because of more erythropoiesis. And also you can see dactylitis, that is a sausage fingers. Okay, why sausage fingers? Because you can see this sickle cell, if they get and destroyed near the fingers blood supply, and there they'll get inflammation, and that will lead to sausage fingers. And there is avascular necrosis of femoral head at you know attached to this process, and glutamic acid to lysine mutation is seen. Now coming to HBC, how to remember? C lysine, glutamic to lysine. There is glutamic to valine substitution, here glutamic to lysine substitution, especially in beta globin. So this causes extravascular hemolysis. Mainly HBC disease causes extravascular hemolysis. There's also a disease called HBSC, that is both sickle cell anemia with HBC. This is one of each mutant gene, milder than HBSS. Blood smear in homozygotes show hemoglobin crystals inside RBCs. So, and also target cells. So how to remember this? HBC disease, there is lysine substitution, and there are crystals inside RBCs. So CCC, that is a HBC. Okay, and target cells also can be seen. And in sickle cell anemia, you can see there is a single base substitution, that is from adenine to thymine. Sixth codon of beta gene is substituted. Next, you can see the complications like risk of hypovolemic shock in children, aplastic crisis of parvovirus attacks, autosplenectomy, that is Howell-Joel bodies, increased risk of infection by encapsulated organisms like Streptococcus pneumoniae, splenic infarct or sequestration crisis. Salmonella can also cause osteomyelitis. There's painful vaso-occlusive crisis, that is dactylitis, priapism, acute chest syndrome, new pulmonary infiltrates on chest x-ray, common cause of that. And there is avascular necrosis, stroke. Sickling in renal medulla will decrease partial pressure of oxygen, that will lead to renal papillary necrosis, that is causing hematuria. Vasa recta occlusion in medulla, hemoglobin erythropoiesis, decrease HbA, increase HbF, increase HbS, but HbA is decreased. Treatment is hydroxyurea, which will try to increase the HbF, and also hydration. Transfusion, marrow transplant. Okay, so this is all about intrinsic hemolysis. Now we'll go to extrinsic hemolysis. In the name itself, you can say extrinsic. Actually, it undergoes mainly in the spleen and also in the liver. So sometimes it may also cause jaundice and splenomegaly, because spleen is destroying more amount of RBC. It will undergo increase in size, and jaundice because liver is also affected. So indirect Coombs test antibody in serum. Here we are going to check out by indirect Coombs test, whereas here in intrinsic hemolytic anemia we'll check the direct Coombs test. Okay. So here the problem will be because of some different conditions like autoimmune hemolytic anemia, microangiopathic hemolytic anemia, macroangiopathic hemolytic anemia, hemolytic anemia due to infection. So here autoimmune hemolytic anemia is a normocytic anemia. It is actually idiopathic and Coombs positive. So if you remember here, paroxysmal nocturnal hemoglobinemia is Coombs negative, but autoimmune hemolytic anemia is Coombs positive. So it is actually divided into two types, warm type and cold type. Warm type is chronic anemia, primarily involving IgG. It causes extravascular hemolysis. So in the name itself you can see autoimmune hemolytic, because of some immunity something is attacking, and that is causing hemolytic anemia. So in warm, IgG will attack, and that will cause extravascular hemolysis. It can be seen in SLE and chronic leukemias, and with certain drugs like beta lactam, methyl dopa. So warm weather is good, you can remember like that, warm good, warm IgG. Next, coming to cold. Cold is acute anemia in which primarily IgM causes RBC agglutination and extravascular hemolysis. So here you'll be having painful and blue fingers, especially seen in CLL and mycoplasma pneumonia infection, and also mononucleosis. There are anti-C3 antibodies which are positive here. So that is the difference between warm and cold. In warm, IgG antibody will attack, and cold, IgM antibody will attack, so that leading to extravascular hemolysis. And findings are spirocytes and agglutinated RBCs on peripheral blood smear. So warm AIHA treatment is steroids, rituximab, splenectomy if refractory, or immunosuppressants. Cold AIH treatment is cold avoidance and rituximab. Microangiopathic hemolytic anemia means RBCs are damaged when passing through narrow vessels. Okay, so this is causing intravascular hemolysis. It is seen in DIC, TTP, HUS, SLE, HELP syndrome, and also in hypertensive emergency. So because of hypertension, blood vessels will undergo vasoconstriction. So when RBC passing through that will undergo microangiopathic. In the name itself, you can see microangiopathic in small vessel. This hemolytic anemia. So according to name only you can understand. Autoimmune hemolytic anemia, according to name only you can understand either IgG or IgM is attacking on the red blood cell, and that is leading to RBC agglutination and extravascular hemolysis. Here also microangiopathy because of small blood vessel, the blood vessel is struck, and that is leading to hemolysis. So here also histiocytes like helmet cells are seen on peripheral blood smear due to mechanical destruction. Okay, and next coming to macroangiopathic, that is the blood vessel is large but still hemolytic anemia. Why? Because prosthetic heart valve, aortic stenosis may cause hemolytic anemia. Second item, mechanical destruction of RBC. Here also you can see cystocytes on the peripheral blood smear. Okay, cystocytes are different from spirocytes, don't confuse with them. Cystocytes means as for example this is a blood vessel. Okay, so as it is passing through this narrow blood vessel, this round cell will convert into some like cut pieces. So that is cystocytes. Where spirocytes is already the RBC is like spirocytes, like a spear. Okay. Now hemolytic anemia due to infection. Because of some infection, there's increased destruction of RBC like malaria, babesia. This will also lead to extrinsic hemolytic anemia. Next we'll start with white cells, that is